So we are going to be doing an NG tube insertion on our patient here. I'd start out by first reviewing the orders that the physician wrote for the NG tube and the exact placement, if it's an NJ, NG, or GI. So I would start by first compiling my supplies, and I'd get a cup of water for the patient so that they can use it for swallowing during the procedure. I would also get some tap water to flush, and I'd grab the syringe, which we're going to be doing this one provided here. It's the NG or EN fit type because you can't use like normal Loralox syringes. We will be using an 18 French for our patient. I'd grab a drape for them. Some lubricating jelly is what we'll be using to lubricate the tip of it, and some gloves, and now we'll begin. So we'll start off with some hand hygiene. I'll don my glove. Well, I'll come into the room. I'll introduce myself. Hello, sir. I'm going to be placing an NG tube today. The doctor would like you to be getting tube feeding, or maybe it's for decompression. Numerous reasons it could be. I'd explain the procedure and ask if they have any questions or concerns regarding it. And then we would move on to getting everything ready at the bedside. I'd start out by inspecting the patient's nares, taking a pen light and just making sure that it's, patent on both sides. There's no, snot or mucus kind of like obstructing anything. Make sure that there's no lesions or abrasions or just really anything abnormal going on with their nasal passage. Make sure there's no deviation or deformities like with the septum. And then we could do a quick test of and making sure that we pick the nasal passage that has the best flow. So once we've done that, I've verified the orders, I have all of my supplies, I've informed the patient. I'm going to do another check of just ensuring the patient's privacy, doing my two-patient identifier and ensuring that I have who I need to have, and then doing it on the right person. And then we'd begin. And so I'd redo some hand hygiene, I'd don my gloves. And we'll begin by having my patient over here. I'm going to have to move this down a little bit. Oh, goodness. Sorry, I don't have a good place to set this up. Okay, we'll work with this. So we've got our patient here. I have everything and we're just gonna get started. So I've inspected my patient's nares, everything looks great. We're gonna go on his right nare. Another thing that we can do is while we are setting up, could have had the tubing in some warm water. I gather that back in the day, some people might have used some ice or something for it, thinking that the coldness would help the patient tolerate it better, but actually it just makes the tubing a little bit more rigid. So anything you can do to ensure that it's not as rigid and it's as pliable as possible is better for the patient. Depending on the purpose of the tubing or what application we'll be using it for would indicate which type of NG tube we use. And it could be Salem sump, which is more often used for decompression. It could be 11. So there's different options for different purposes. So we have this. We'll just say I put the end in some warm water. It's nice and pliable. We're going to measure from the nares to the earlobe and then down to the xiphoid process. So we're just gonna guess that. There we go. And we'll just say we're at 45. And so at this point, we would mark it with either an applicable marker, or you'd take the tape and wrap it around right there. So we're just marking it. You'd want to get your lubricating jelly and lubricate the about first 4 inches of the tubing. We'd want to make sure that the position of the patient, which my patient is in high Fowler's, as you can see, we'd want to make sure that they're, at least Fowler, somewhat upright. And at this point, I am now going to begin. So we've lubricated, we're all ready to go. I've got everything here ready on, let's say, the bedside table. Let me just open that up. Okay. So for our patient, we're going to be going in to 45. If this were going to be like NJ placement, then you'd want to add an additional 20 centimeters, 20 to 30 centimeters. So I have, let's say, the patient draped at this point. We've measured it out, we've marked it, now we're going to insert. While we're inserting at the beginning, we're going to have the patient kind of hyper extended a little bit for good access and visibility. We'll go in, and then as soon as we get to the back, so let's go in, doing great. There is, no resistance, patient's doing fine. We get about partway there, just to about the back of the throat, and just before we proceed, we want the patient to tilt their head forward, which will help close off so that we don't end up going down the trachea. And we want them to swallow, and I'll give him a glass of water and have them take little sips and swallow. And about every swallow that they do, we'd want to make sure that we advance the tubing about 5 to 10 centimeters. And so we'll have them swallow and swallow and swallow, and they're doing good. And throughout this, we'd want to assess and make sure that they're tolerating it well. If they have the gag reflex, or if they look to be like they're, in respiratory distress or becoming cyanotic, we'd want to stop. If we get to the gag reflex and it's just too hard for them, we could pull back, even take it out if we haven't gotten that far, relubricate it, let them rest for a second, regain themselves, and try again. But my patient's tolerating it quite well, so we're going to keep on going, and swallow, and swallow, and they're tilted forward at this point. And we're gonna go, and we're there. So at this, now that we've got it there, we would want to take some tape, fasten it. Sometimes they have fastening devices that are included in the kit, not with ours. So we'd tape it in place. We wouldn't let go of it until we had it secured. And then I'd want to secure it like such, also to the patient's cheek. And if this was going into the intestine, we would, while we're waiting for confirmation of placement through x-ray, we'd want to make sure that we kept the patient on the right side until placement had been confirmed. We still would use x-ray. That's the most reliable source for verification of placement or proper placement. And so that would be something before you could actually administer any tube feeding or begin suctioning or administer any medication. You would definitely have to wait until you had the results back for that. We would, while we're waiting, aspirate the gastric contents. In order to do that, we would grab our syringe and draw about 30 mLs of air. It's debatable at this point whether introducing 30 mLs of air and listening for the whoosh sound is an appropriate way or a viable way of assessing placement of the gastric, of the NG tube, like into the stomach. It seems like newer research doesn't support that practice anymore. For us right now, we're going to introduce 30 mLs of air and then aspirate gastric content. And we don't need a whole lot because at this point we just want to make sure that we test it to make sure that we're in the right spot. pH should be anywhere from 1 to 5 for the gastric content, depending on placement. It could be, above 6, but it just depends on where the tube is placed. And so once we've aspirated, we would put that content into a little container. We'd get our pH strip and we'd check it against the key that it comes with and be able to identify what the patient's pH is so that we could make sure that we weren't in the airways and we're actually in the right spot, or that we didn't advance it too far and we're not in the intestine when we need to be, in the stomach. So we have tested our patient's pH. It's secure. We'll say pH is 3. It's, looking like we were able to successfully place it. We would order or wait for x-ray to come and verify that. And should it be verified, then we can hook the patient up to their either continuous feeding or intermittent feeding, which would be maybe, 30, 45 minutes in duration, about how much a normal meal time would be, or a bolus application. And then after, making sure that everything's placed, we also want to make sure that we had placed the date and time that it was applied. And that could just be on one of the pieces of tape that are on the NG tube and securing it. And we would want to make sure that for just a regular NG tube, we keep the patient in HIFU for about an hour afterwards, and that within 30 minutes of placing it, that we reassess their status, and just make sure that everything is secure and still attached. The patient hasn't been tugging on it, they're not confused or disoriented, and that, you know, they're not at risk of pulling it out or harming themselves in that sense. Like I said, we could do the auscultation of the over the epigastrum and, you know, listening for that whoosh, but not necessarily indicated in all texts nowadays. And then the proper documentation for this patient would be Farrell's record, where you're identifying the pH, the amount of gastric content that was aspirated from the stomach, the quality and color of it, any notable characteristics, any, you know, if it tended to be dark and red, indicating maybe a bleed or something, or ulcerations. So you'd want to take note to all of that, any undigested food. You'd also want to document the patency of the tubing, if it's easily aspirated or not, if it seems to be occluded, which is also why it's very important to flush it before and after any administrations. And obviously, if you're going to be disconnecting the patient from tube feeding, make sure that it's flushed with some fluids, because the tube feeding can be some pretty thick and sticky stuff. So it can occlude the tubing pretty easily if it was left in there. We would want to make sure that, you know, there wasn't any untoward effect, and that's about it. Obviously, we'd want to keep the patient upright until everything was verified, instruct the nursing assistant to be alert and notify myself or another staff member if the patient becomes in respiratory distress or seeing any signs of irritation going on with the skin or anything around the area of application, and just make sure it all looks good. And so I would make sure that my patient has a call light beside them before I leave, ask if they have any other questions or concerns, and perform hand hygiene, and leave and make sure I document everything appropriately and how the patient was able to tolerate it. And that's it.